Today we will discuss about pulmonary embolism. It is very important. So, see, basically, always think of a patient who has shortness of breath, which is sudden onset. This is very important. So, sudden onset of SOB, and whenever you auscultate this patient, the lungs will be clear, and there will be no reason, there will be no history of any fever, vomitings or anything, just SOB, sudden onset, and lungs are clear. So your first thought should be on pulmonary embolism. And also the history also plays a major role in this. See, so patient, if you are suspecting pulmonary embolism, immediately you have to look for any DVT, because most of the times DVT, patients having DVT land up into pulmonary embolism. The blood clot in the venous system in the legs travel to the lungs, and that will lead to the pulmonary embolism. And at the same time, you should ask the patient whether he had any surgery in the previous, like for example 15 days, 15 to 20, like 2 to 3 weeks. See, for example, patient had hip surgery and this patient is bedridden for some days. So what happens, the stasis in the venous blood that will develop into DVT, and then progressively the patient lands up in pulmonary embolism suddenly. So the most common is hip surgery or any surgery to legs. And one more thing, suppose if the patient is in having sedentary lifestyle, where maybe he is, like for example IT professionals, usually these people will be having DVT, that will also lead to pulmonary embolism. And the other one is cancer patients. See, cancer patients who are taking chemotherapy, who is on chemotherapy, the most commonly they will be having pulmonary embolism. So always remember these cancer patients coming to the ED with SOB, first you think of pulmonary embolism. And one more thing, sepsis, septic shock landing in DIC, disseminated intravascular coagulation, and shock may also present with pulmonary embolism. Okay. And now that you are suspicious of having this patient in pulmonary embolism, immediately what you will do, you will take the ECG. So what are the ECG findings? As you know, S1, Q3, T3. Lead 1, there will be small R wave and deep S wave. And Q3, T3, lead 3, negative deflection Q wave, and then QRS complex and T wave will be inversion. T inversion and Q wave will be there. S1, Q3, T3. But remember that not all patients will be having S1, Q3, T3. Okay. And this is one. And the second one is incomplete right bundle branch block. See, I am calling it as an incomplete. So what is incomplete bundle branch block and complete right bundle branch block? Incomplete is like the QRS complex will be less than 3 small boxes, or less than 0.12 seconds. That is called incomplete right bundle branch block. So always remember S1, Q3, T3 and incomplete right bundle branch block. And the patient is in SOB, why not take an ABG? ABG will show respiratory alkalosis because patient will be hyperventilating. And the next one, then you call to the echo person to do echo will be showing RA-RV dilation. So why there is an RA-RV dilation? See, suppose this is the right atrium and this is the right ventricle. From here you will get pulmonary trunk, and then it will divide and it will go to lungs. So usually what happens, suppose there is a group of alveoli here and which is supplied by one vein, and these are the another group, one vein, and this is a continuation of the pulmonary trunk and the related veins. So what happens is, like, suppose there is a, I am picking up the red, suppose there is a thrombus here. So there is a thrombus here. So what happens, there will be no blood going to this alveoli for oxygenation. So our lungs will be having a very good mechanism, like whenever there is no blood supply to the one area, the blood will be diverted to other segments. So that is a compensatory mechanism in our lungs. So now what happens, so this will get blocked and there will be, heart will be pumping the blood and there will be congestion. All the blood will get jammed to the other side. Because of the congestion there will be backflow, and this will cause dilation of the right ventricle, and when the right ventricle is fully loaded, and then it will cause backflow to the right atrium, and this will also cause the right atrium to enlarge. So that is why we call it as RA-RV dilation, right? Yeah, and now, and you have to know about the well score. There is a scoring system for DVT and pulmonary embolism. So always you should have a picture of the table in your phone. Whenever you suspect a pulmonary embolism, just open that well score and do the scoring. And regarding the investigations, you will send the D dimer, and if you are very sure about this patient is having pulmonary embolism, you should go for CTPA, CT pulmonary angio. And so for the treatment part, see, clinically you have to connect all these dots and you will get the diagnosis for sure, damn sure, and give him low molecular weight heparin like Clexane. If he is adult, 60 mg. Normally the Clexane we can give like 0.5 to 1 mg per kilogram. Yeah. So always remember, sudden onset, that is not progressive, sudden onset, and lungs will be clear. Yeah, that's it.